what are the questions, at least the 5 or 6 questions which a doctor can ask the patient in the district clinic to differentiate between a true vertigo and the other conditions?
In fact, the complaint of vertigo, in Malayalam we call talagarakam or dizziness, is the most commonly abused word in neurology literature. For a patient, each and everything is so-called talagarakam or vertigo. The so-called vertigo or talagarakam may mean anything. It may be true vertigo, or it may be just a dizziness which may be due to heaviness of the head, a feeling of imbalance, unsteadiness, blurring of vision, diplopia, even loss of consciousness may complain of dizziness. So, how to differentiate a true vertigo from dizziness is, first is the description of symptom may give a clue. For example, the sensation of spinning, sensation of feeling drunk, sensation of motion sickness or imbalance, those symptoms usually favor a vertigo. On the other hand, spinning sensation inside the head, floating sensation or swimming sensation, or feeling of near faintness are non-vertiginous symptoms. The problem is that sometimes a true vertigo patient may not complain of a spinning sensation, may only a vague dizziness or heaviness. In that case, how do you differentiate a true vertigo from a pseudo vertigo or dizziness? In such situation, such symptom, if it is associated with autonomic symptomatology like vomiting or sweating, that symptom is more likely to be a vertigo. Secondly, the symptom worsening with change of position or turning around or bending down are more often suggestive of a vertigo than just a simple dizziness. But here, one caution should be exercised is that vertigo which occurs when getting up from sitting position need not be a vertigo, can be due to a postural hypotension, as you all know. Thirdly, the vertigo is almost episodic. If somebody complains that I have got a continuous vertigo from morning till evening, it is unlikely to be true vertigo. Of course, you can ask for associated symptomatology like deafness, tinnitus, or some symptoms like diplopia, numbness, etc. If they are present, you can be easily think that is likely to be a vertigo. The common symptoms which can be confused with vertigo can be medical causes or systemic causes, psychological causes, or even neurological causes. The two common medical conditions which come with the diagnosis of a vertiginous symptom is one is fainting, near faint dizziness, or due to decreased cerebral circulation. As you see in postural hypotension, vasovagal syncope, cardiac syncope, or hyperventilation syndrome. The second medical condition which comes with ED is hyperglycemic episodes. The psychological cause, the most common one, is can be seen in panic attack or obsessive compulsive disorder, depression. Here, the usual symptom is not true vertigo. They complain of floating or swimming sensation or spinning inside the head. Among the neurological causes, the most any cause of disequilibrium may be due to proprioceptive sensory loss or a postural imbalance due to some typical Parkinsonism or a double vision itself. They can complain of can be another country walking on a boat, standing on a boat. This usually occurs after a long travel when the patient walks about a long travel, especially after sea travel. This is a result of a vestibular adaptive process to the continuous passive motion during travel. Yet another condition which can be confused with vertigo is oscillopsia. Oscillopsia, as you know, is a subjective illusion of movement of the objects. This can be easily differentiated from vertigo that the oscillopsia will disappear the moment you close the eye, whereas vertigo will persist even if you keep the eyes open or closed. The other neurological condition which can be mimicked is the triple PD, otherwise called the persistent postural perceptual dissonance, which actually is not true vertigo. A feeling of imbalance the patient continuously feel all the time when they walk about. These are the common mimickers of vertigo I come across. Among all the three things, the three things which I commonly come across is one is postural hypertension, second is the triple PD, that's a persistent postural perceptual dissonance, and The episodic imbalance we get in atypical Parkinsonism like PSP. I had two patients who had only presented with, I went to the ENT surgeon for combined dizziness, that they immediately found they have a case polycystic ovaritis. So their postal imbalance may be confused easily with vertigo because they have an unexplained fall. Examination may not show any features of Parkinsonism. So these 3 things has to be kept in mind as a different diagnosis of vertigo symptoms.
So probably the take-home point from the second question is, as a neurologist, many a times a patient comes to a neurologist after consulting so many ENT surgeons or so many other doctors. So the things that a neurologist should think in such a situation, one is the postural hypotension. So always probably they should check the BP in the lying and the standing position, as well as the think of episodic symptoms, the episodic dizziness that can occur in patients who have PSP, and also the triple PD entity. So coming to the next question, it is a common belief that an isolated vertigo is almost always due to a peripheral labyrinthine problem. So do you think that's it's correct?
No. Isolated vertigo can also occur due to strategic lesions in the various parts of the brain, commonly in the brainstem. For example, a small infarct localized to the nodulus, root entry zone of the eighth nerve in the brainstem or the vestibular nucleus can cause vertigo without any other neurological symptoms and signs. Rarely, lesions involving the flocculus or dorsal insular cortex can also cause isolated vertigo. I'll show this particular MRI showing a nodulus infarct. This patient is presented only with isolated vertigo. So also this patient with infarct in the root entry zone of the eighth nerve, vestibular nerve, and this is a nucleus. This is the infarct in the vestibular nucleus here causing isolated vertigo. This is a dorsal insular cortical infarct, which can also present with isolated vertigo. That is a zone where the vestibular fibers end in the cortex. And even this is the flocculus infarct, which can cause isolated vertigo. So it's vertigo, isolated vertigo need not necessarily mean that the lesion is periphery. It can occur due to brainstem lesions.
So can you go back to that previous slide now where that insular cortex?
Yeah.
So this is new information, sir. Insular cortex infarction presenting as isolated vertigo.
Yeah. In fact, this is not very common, but this is described in literature because this is the area, this is the vestibular cortical zone just behind the interstitial scalus, where the vestibular fibers ultimately end. So this is the site. This is also incidentally the site where you can have a vertiginous epilepsy. So the lesion there can produce isolated vertigo. It is known but rare.
This is one of the most difficult thing and the most commonest thing which we see in our clinical practice. An elderly patient who comes to the casualty or the outpatient department with acute onset of severe vertigo and imbalance. The usual two things that comes to our mind is one is a vestibular neuronitis and second is a vertebrobasilar stroke. So these are two things many times we write as DD, but how to differentiate between these two?
As Dr. Gigi said, it's very crucial to differentiate because one is a very benign condition, the other is a very sinister condition. Even though vertigo is a disorder of the vestibular system, it is the eye you have to look for and not the ear. The three things you have to look in the eye. One is the type of nystagmus, which can differentiate between the two. Second, eye position, that's the process of skew deviation or not. Third is one bedside test called head thrust or head impulse test. And let's come to the nystagmus first. The type of, looking at the type of nystagmus, you can show the slide. That in the peripheral vestibular nystagmus, it's a direction fixed nystagmus. As you can see, it beats only to one direction, to the left side here. On the other hand, in the case of a central nystagmus or central vestibular disorder, it is a direction change in nystagmus. When you look to the left side, it beats the left side. Or look to the right side, it beats the right side. On the other hand, peripheral nystagmus, whether you look to the right side or left side, it beats only to one direction. I'll show one video of the patient. You can see the video here. If you look very carefully, there is a nystagmus is beating to the right side. On looking to the left side also, it is beating to the right side. It become increased on the primary position, again beating to the right side, and looking to the right side also, it is beating to the right side. So it's a direction fixed nystagmus. And if you find a nystagmus like this, always think of a peripheral vestibular disease or labyrinthine problem.
Sir, can I interrupt for a moment?
Yeah, please, yeah.
Because this lecture is actually intended for general practitioners, physicians, as well as ENT surgeons. For the specialists who are not in neurology, many times examining the nystagmus becomes a problem, and most of the people don't look at it. So they don't evaluate the nystagmus properly. So can you just go through that slide once again, sir?
Yeah.
That video once again, sir.
Yeah, I'll come back to the slide once again. In the case of peripheral nystagmus, the nystagmus beats only to one direction. So, for example, I got a left-sided labyrinthine and peripheral lesion. The nystagmus beats to the right side. When I look to the left side or look the primary position, as well as on the right side, when I look to the right side, the nystagmus beats only to the right side. So, on the contrary, in the case of a central lesion, the nystagmus direction changes when you look to the right side and to the left side. In the lower panel, you can see the patient is looking to the right side, nystagmus beats to the right side. When the patient looks to the left side, nystagmus beats to the left side. Such direction changing nystagmus when you look to the right and left favors a central pathology. On the other point which can be used at the bedside, differentiate peripheral versus central, is that to find out the nystagmus amplitude increases on avoiding fixation. Now, how to make the patient avoid fixation is classically by the Frenzel's glass, which is a 30 plus diopter lens. But one easy bedside technique is you can use the ophthalmoscope. By use of ophthalmoscope, you can look at the fundus of the ophthalmoscope and look at the optic disc. You can find the movement of the by looking through the ophthalmoscope and then avoiding fixation. When you do like that, if you find the nystagmus is increased or accentuated, it favors a peripheral lesion. So here, and you can see in this diagram here, when the fixation is removed, you find the nystagmus amplitude increases on looking to the left side compared to the one which was present when the fixation is not there. On removing the fixation, nystagmus also appears when the patient looks to the right side. Not only so, that means there's accentuation of the nystagmus on avoiding fixation. On the other hand, in the case of a central nystagmus, there is no change whether you avoid fixation or not. So the avoiding fixation does not help in increasing or improving the amplitude of the nystagmus in central lesions. The other thing you look for to differentiate between peripheral and central nystagmus, central disorder, is the eye position. Look for the skew deviation. By skew deviation, we mean that one eye is up and one eye is down. Mind you, to call skew deviation, this vertical disconjugation should not be due to an extraocular muscle paralysis. So, for example, a vertical move or vertical or elevated depression also can produce disconjugation like that, but that should not be there to cause a skew deviation. The bedside how can differentiate is that by duction movement, I close one eye and then look for the ocular movements. It's all normal in skew deviation. There is no restriction anywhere, unlike a paralytic strabismus where there is a restriction. So this skew deviation indicates that the lesion is central. Here you can see in this particular picture, the left eye is low, the right eye is up. So that means here, this is actually, I did not want to go to the pathophysiology of skew deviation. This indicates a lesion in the pathway connecting the otolith organs to the interstitial nucleus accumbens in the brain. It crosses to the, it reaches the same side, vestibular nuclei, crosses and ascends in the MLM to the interstitial nucleus accumbens. So lower eye indicates a lesion in the lower part of the brainstem or cerebellum. That means lesion is in the medulla or the lower pons. The upper eye indicates that the lesion is on that side, that is in the after crossing. That means in the upper pons or in the midbrain. So that gave very good site of lesion. But anyway, What we are interested in is presence or absence of skew deviation. If it is present, you think of a central lesion. Sometimes this mild disconjugate is very difficult to detect. So what you have to do is what is called the alternate cover test. You can put an occluder, you change from one side to other. You can see the vertical movement of the eye when you change the occluder from one eye to other, cover from one eye to the other. So that by that we can differentiate whether the patient has got a skew presence or skew deviation or not. The third test or bedside test and the most useful test is what is called the head impulse test or head thrust test. Now, before to understand what is a head thrust test, you must know something about the vestibular ocular reflex. Vestibular ocular reflex is a reflex which make you capable of focusing of your eye or your macula exactly onto the object, irrespective of head movement. Suppose you are jumping and catching a ball, you still catch the ball exactly. This is because of the intact vestibular ocular reflex. Irrespective of head movement, the eyes are focused onto the object. So, for example, in this picture shown here, when you want to look, the patient is looking to the left side. The left labyrinth is activated. You can see it's an activation here, and that produces a corresponding movement to the opposite side. The equal and opposite movement of the contract, and the eyes turn to the opposite side. So what happens? Eyes continue to remain on the target. Now this is made possible by this pathway, that is the peripheral labyrinth. It goes to the vestibular nuclei. From there, cross the opposite side, reach the gaze center, from which is connected to the contralateral lateral rectus and ipsilateral medial rectus, make you to look away from that particular to the opposite side of the vestibular stimulation. This is the normal vestibular ocular pathway. What happens if there is lesion in the labyrinth? Let us see, he has got a defective labyrinth on the left side here. When you turn or jerk the head to the left side, that labyrinth is not activated. So what happens? The eyes moves along with the head. So it moves towards along with the head. But then you have to make a corrective saccade to bring back eye to the target which are intended to look. So that is called a catch-up saccade is occurring. So what we are observing in head impulse test is looking for a catch-up saccade. If catch-up saccade is present, that side is defective. Which side is deviated, that side is defective. I'll show the video of this particular patient. Here, I am moving a rapid head movement towards the left and right. To the left side, you see it's got a catch-up saccade.
Can you show the video, sir? The video is not.
Pardon?
You have to advance the slides.
But I can see the. Can you not see the video now?
No.
I'll show it one second. Okay. Can you see the video now? No.
Yeah, now we can see.
Okay. Yeah. When you jerk the head to the left side, the eye, right side nothing is happening. The eyes are focusing on the face itself. On turning the head to the left side, they make a corrective saccade. I think I'll show the video once again because it was interpreted in between. Jerk the head to the left, there is a catch-up saccade. On the other hand, when you turn the head to the right side, there is no catch-up saccade. Eyes are focusing on your nose. Again, turning to the left side, you can see the catch-up saccade. That means there is a defective labyrinth on the left side, suggestive of peripheral visualization. Now, what is the usefulness of head impulse test is that it indicates a lesion in the peripheral, usually indicates lesion in the peripheral. But it's got certain pitfalls which will come to later on. So, what the three things which I told you, one is the head impulse test, presence or absence of skew deviation, and nystagmus can help the doctors. There is a peripheral central lesion. The head impulse test favors a peripheral, but rarely it can also occur with the vestibular root entry zone. So what is important is that in acute vestibular syndrome, a negative hit favors a central lesion. Nystagmus, I already told you, unidirectional nystagmus favors a peripheral lesion, but it is not that it can only occur in peripheral, it can also occur in central lesions rarely. But bidirectional nystagmus, pure vertical, pure torsional nystagmus favors a central lesion, and presence or absence of skew deviation. Presence of skew deviation suggests a central lesion, but absence of skew deviation may occur with peripheral and central lesion. So the point here to remember is that all the three things should be present, should be abnormal, or should be present to diagnose a peripheral lesion. That means the impulse test should be positive, the nystagmus should be unidirectional, and there's no skew deviation to call this a peripheral lesion. If any one of them is favoring a central lesion, think of a central lesion. So all must be present to diagnose vestibular neuritis. If any one of these findings favors a central lesion, suspected brainstem lesion. Now, it may feel counterintuitive that, say, a normal finding, that is a normal head impulse, suggests a sinister condition like a brainstem lesion. So make sure that head impulse test is important, positive, be considered positive only if the patient comes to you with a acute vestibular syndrome and has got a nystagmus. Imagine a patient comes with a dizzy patient due to some urosepsis or some other panic attack, etc. They come to you with the dizziness. And if you do the head impulse test, it is negative, don't jump into the conclusion it is central lesion. So that's why it should be taken importance only when there's got an associated nystagmus. Next question.
Yeah, the next question is, can a direction horizontal or horizontal rotary nystagmus occur in brainstem lesion? So that is the common doubt. Does it always suggest that it's a peripheral lesion?
Yeah. In fact, this can also sometimes occur in brainstem lesion, especially the medullary lesion. It can occur. Again, okay. Medullary lesion can occur where this is called the pseudo-vestibular nystagmus. I will show you a video how to video this patient, showing the nystagmus here. Here you can see is a patient with lateral syndrome on the left side. He has got nystagmus beating only to the right side. Only one direction it is beating. On look to the left side, you can also make out a mild rotary component as well in this patient. Now, in that case, you may ask how to differentiate a peripheral unidirectional nystagmus from a central unidirectional nystagmus. It's difficult. By nystagmus alone, it is difficult to differentiate the two. You look for the associated symptoms or signs. One is presence of skew deviation. In medullary lesion, almost invariably they have got a skew deviation. The skew deviation is the lower eye is the same side of the lesion. Other thing which you can look for is what is called the lateropulsion, in the sense that in medullary lesion, what happened? The eye has got a tendency to get deviated to the same side of lesion. We call it is pulsed towards the same side, called ipsipulsion. And a preference to keep the go to eye to the same side of the lesion. For example, in this particular patient, I'll show you the nystagmus once again. It's got a nystagmus beating to the right side. It's got a mild rotary component also. Now, I'm asking the patient to close the eye for a period, half a minute, and open. You see the eyes coming back to the primary position. When you close again, eyes again, the eyes has gone back to its pulsed position, that lateral deviated position. The moment you open the eyelid, it comes back to the primary position. This is another way to find out the lesion is in the brainstem. This will not occur with the peripheral labyrinthine lesion. So associated with skew and a lateral pulsion tells you lesion effect in the medulla rather in the periphery. Otherwise, by nystagmus alone, you can differentiate the two.
Sir, can you go back to that hip video? No, the hip test video was not shown. Can you show that video once again, sir?
Yeah, this one, no?
Yeah. That video was not shown. Head impulse test.
In fact, I'll show once again. The patient is suddenly jerking the head to the left side. I am jerking it to the left side. You can see the eyes make a catch-up saccade to the right. On the other hand, when you turn the head to the right side, there is no catch-up saccade. That tells you that the left side, there's going to be left-sided peripheral vestibular lesion. can see once again, I make the jerk to the left side. There is a catch-up saccade. You can see the eye making a saccadic, correctly saccade to the right side. That can see again. Okay, Vijay?
Now, one of the common thing which people ask is, so many tests, the hip test, all these things, evaluating the nystagmus to differentiate between a peripheral and a central. Why not just do an MRI and try to differentiate?
Yeah. In fact, MRI can be done to differentiate. The problem is that in 15 to 20% of the individuals with acute vestibular syndrome due to brainstem infarct, the infarct will not be seen. Brainstem may be normal, so-called diffusion negative MRI. So in such a case, if you are able to detect the infarct by MRI, you are lucky. You can differentiate the two. But in the 20% the acute phase, you may not be able to pick up the lesion. So there, the test becomes handy in such patients. And not that all patients can afford MRI in the middle of the night, coming to the hospital to do an MRI will be practically difficult.
So in that situation, what to do, sir?
Now, the things, this is called hints plus. The previous three tests were called the hints. Now I'm talking about the hint plus. The two other additional tests which you can do to differentiate central versus peripheral lesion in such scenario. Now,
Can you share the
presence of
slide also,
yeah,
sir?
one is the presence of deafness. All along, we have been taught from school days that when you get vertigo with the deafness and tinnitus, it thinks of a peripheral lesion, peripheral. But nearly 90 to 95% of the instances of acute vertigo peripheral lesion, there is no deafness. They are present only with severe acute vertigo. There are no tinnitus and no deafness. Now, in fact, deafness is more common with the central lesion than peripheral lesion. So this is because the infarct causing the vertigo is usually due to the ICA infarct, anti-inferior artery infarct. That artery is also going to supply the cochlea and the labyrinth through the labyrinthine artery. That also get compromised. So a vertigo associated deafness is more common with ICA infarct than a peripheral vestibular neuronitis. So whenever you get an audiovestibular symptom, deafness plus vertigo, always keep brainstem lesion in your mind. Because I will show this particular case history. This 50-year-old hypertensive man, person history of acute onset of fullness and tinnitus in the left ear, followed by unsteadiness in walking for 2 days duration. Examination, there was gaze-evoked nystagmus. Head thrust was positive on the left side. Gait attacks were minimal. Rest of the examination was normal. Well, see, they can see the video here. We can clearly see the head thrust positivity when the patient ejects the head to the left side. So you can see the positive head thrust. And it's got a mild gait ataxia. So we're looking at the patient, except for the nystagmus, everything favors a peripheral lesion. But this is what is seen in the MRI here, the infarct in the vestibular and root entry zone due to neck pain. The clue was that he also had associated deafness, and the type of nystagmus was here able to help us differentiate between the peripheral and central. The other thing which you can do is the balance, in the sense that, as you know, vertigo is a hallucination. In peripheral lesions, however severe the vertigo is, the patient still can walk about without the help of a person. They hold on to something and come to you. A person is brought to you with two people holding on to the patient. You think of a central lesion because there is a true imbalance, true ataxia in central lesion. So if somebody is there, cannot sit without support or stand without support in vertigo patient, think of a central lesion as we consider that should be rolled out in all the it should be rolled out immediately without any other causes. So summarizing, these are the points by which you can differentiate central versus peripheral. The nystagmus is horizontal nystagmus, horizontal rotary and peripheral lesion. Central lesion produces direction changing nystagmus or gaze-evoked nystagmus. Pure nystagmus vectors, pure rotary, pure vertical, whether it's upbeat or downbeat, whether central lesion. The nystagmus is accentuated by avoiding fixation, think of a peripheral lesion. If it is not affected by the avoiding fixation, think of a central lesion. Pathology is usually impaired in peripheral lesion, whereas intact, most of the time intact, except the situation which I told you in central lesion. Skew is absent in peripheral lesion. Central lesion, it is usually present. Gait in peripheral lesion patient can walk unassisted, whereas central lesion patient cannot walk unassisted because they need support of walking. So these are the findings by which you can differentiate between a peripheral and central lesions.